So the patient is a 68-year-old male with a history of coronary artery disease, status post-CABG, coronary artery bypass graft in 2002, history of pulmonary embolus and deep vein thrombosis in 2002 and 2009. Now presents with nausea, vomiting for the past few days, along with dyspnea on exertion, and a pulmonary embolus in the right lower lobe. His most recent story, and his story changes fairly frequently. He also has multiple ED visits at our hospital, and also at Fairmont Hospital for nausea, vomiting, and was also discharged on the same day at all of those places. So he was admitted to the holding unit basically for IV hydration, and he was also given Ativan there for alcohol withdrawal. He was satting 90% on room air. His hematocrit was 40. EKG didn't show any changes from prior visits, and tropes were negative. Creatinine was 1.5. Ethanol tox was negative. However, he became increasingly tacky overnight, and per Dr. Stevens' note, his CT came back showing the right lower lobe PE. Currently, the patient was not on any Coumadin. This is a little vague.
When I reviewed the history, it appeared that his pulmonary embolism occurred during vascular surgery.
Yeah, it may have occurred following the surgery, but it just isn't clear right now.
The recent PEs were documented at the outside hospital records. We just don't have those records yet.
Moving on to relevant past medical history. So he has a history of coronary artery disease, an eye surgery, and I'm not really sure which eye or what kind of surgery it was, a hernia repair, an appendectomy.
Which surgery do you think is the most pertinent?
I think, well, maybe his coronary artery disease is the most pertinent here, because that's kind of
Okay.
Well, it sounds like he had an aneurysm repaired, and that contributed to his chest pain.
Oh, okay.
And it was at that time that he had his PVCs. I'm not sure whether he had a PE at that time or what.
yeah.
Okay.
It's not really clear about that right now.